We're live. Hello, everyone, and welcome to the New Jersey Division on Civil Rights webinar titled The State of Black Maternal Health, Examining the Racial Disparity. Before we get started, I'd like to go over a few housekeeping items so you all know how to participate in today's event. This program will be recorded, and given that this is a webinar, guests will not be able to be seen on camera. Nonetheless, as an audience, you do have access to drop questions in the Q&A tab, and you have the option to submit questions anonymously. All audience members' cameras and microphones will be off as well. Due to time constraints, we ask that you please keep all questions on topic. And please note that any questions we do not get to this evening will be answered as a follow-up after the event. You may also email us at communityrelations@njcivilrights.gov. Resource links and contact information will be shared in the chat throughout the program. And if you experience any technical difficulties tonight, please explain your technical issue via the chat function, and we will try our best to address the issue. Lastly, please follow the Division on Civil Rights on Facebook and Twitter at Civil Rights NJ for the latest information on news, resources, and information from our office. Now, I'd like to introduce Tisha Leonardo Santiago. Tisha serves as the Interim Director of Outreach and Community Relations for the New Jersey Division on Civil Rights.
Thank you, Tabitha, and good evening, everyone. Black Maternal Health Week is held annually on April 11th through the 17th. Now, this is a week-long campaign founded and led by Black Mamas Matter Alliance, and is to build awareness, activism, and community building to amplify the voices, perspective, and lived experiences of Black mamas and birthing people. The week is intentionally held during National Minority Health Month. It begins on April 11th annually to join dozens of global organizations in marking this day as the International Day of Maternal Health and Rights, an opportunity to advocate in eliminating maternal morbidity globally. Currently, New Jersey is ranked 36th in the nation for maternal deaths. The sad reality is that a Black mother in New Jersey is 7 times more likely than a white mother to die from maternity-related complications. In 2019, First Lady Tammy Murphy launched Nurture New Jersey, a statewide awareness campaign committed to reducing maternal and infant mortality and ensuring equitable care among women and children of all races and ethnicities. This campaign focuses on improving collaboration and programming between all departments, agencies, and stakeholders to make New Jersey the safest and most equitable place in the nation to give birth and raise a baby. But tonight we focus on the state of maternal Black health, examining the racial disparities. Our powerful panel of speakers will explore with you, the audience, the causes of the racial disparity that are seen in health outcomes for expecting Black parents, examine historical and systemic racism in access to reproductive care and the impact of disparity we see today, identify and look at different support services and resources that are important to expecting parents, highlight the importance of care support, not just for the doctors, but also from the community. Identify current initiatives today to tackle maternal health disparities. We hope you better understand the racial disparities around maternal health, the resources and support that can be used during pregnancy, how people can become more involved on the topic and in advocacy. But most of all, this is an important topic for everyone to be aware of and be involved in, not just Black expecting parents. Without further ado, it is my pleasure to turn tonight's program over to our moderator for the evening, New Jersey Division on Civil Rights Community Relations Specialist, Kai Durant.
Thank you, Tisha. I also wanted to give a special thanks to our panelists for joining us today. As Tisha said, this is Black Maternal Health Week, so we definitely wanted to highlight Black maternal health and raise more awareness about it. I'm going to briefly do a brief introduction of each of our panelists. I'm going to go over their bios very brief, but in the chat, we will link a longer, more in-depth bios for each of our panelists. So to start, we have Crystal Charlie, who is a reproductive justice and civil rights activist. She is a respected community organizer and advocate. She's a proud mother and also a patient advocate for Black maternal health, and she's the founder of Melanin and Maternal Wellness. She is a Shafia Monroe consultant full circle doula birth companion, providing perinatal doula services, included prenatal, labor and delivery, and postpartum care. She is also a childbirth educator. She is a senior organizer for Salvation and Social Justice, leading the organization's campaigns around Black health equity, environmental, and economic justice. Our next panelist is Dr. Lisa Giddens-Williams, who's a graduate of Cornell University and Temple University Medical School. She completed her residency in obstetrics and gynecology and fellowship training in maternal fetal medicine at Rutgers, New Jersey Medical School in Newark, New Jersey. She is the director of OB at University Hospital in Newark, and she's also a professor in the Department of OB and GYN in Women's Health at Rutgers NJ Medical School. She's a practicing maternal fetal medicine specialist. She serves as the chair of the Maternal Health Awareness Day Committee for the American College of Obstetrics and Gynecology. In her role as Director of Obstetrics at University Hospital, she is a patient safety officer leading quality improvement and safety efforts. Her focus has been on the implementation of a nationally recognized perinatal safety initiatives and development of new models of patient care. And then our third panelist is Erin Williams, who's an experienced and versatile attorney who works to champion the principles of equity, justice, and opportunity over civility or respectability. She is barred in New Jersey, New York, and the Southern District of New York, but has appeared in various courts around the country. She's an experienced civil rights litigator, social, racial, and reproductive justice movement lawyer, and proud criminal defense attorney. Simultaneously, Erin is the Chief of Strategic Initiatives and Enforcement with the New Jersey Division on Civil Rights. In her current role with DCR, she leads the team that advances statewide policy and proactive enforcement, recently resulted in a historic multi-million-dollar Red Lion matter with the DOJ. In her immediate past position, she was a senior staff attorney for National Advocates for Pregnant Women and which is a national legal nonprofit that advocates for and represents pregnant people who were charged with criminal or face punishment related to their pregnancies. And I thank all the panelists for joining us today, and I'm really excited to get into our conversations and start the discussion. So my first question, I'm going to direct it to Dr. Giddens-Williams, but everyone can join in and contribute to it. So since we're talking about Black maternal health and disparities, Dr. Giddens-Williams, what is the current status of maternal health disparity and what are you seeing in your field?
Well, thank you for that, and thank you for having me here today. I think the numbers that you reflected in New Jersey with a six-fold difference in maternal mortality for Black women than non-Hispanic whites, pretty much mirrors the country. And so the maternal mortality statistics for 2021 came out earlier last month, and 1,206 women died related to childbirth in the United States. And that number is far greater than any other developed country. And one could say that it is because the United States is a heterogeneous population, there are multiple races, languages, cultures, but even when you looked at non-Hispanic whites, the mortality rate is high. So the United States is in trouble. And so those rates that we see in New Jersey fairly much mirror the country. And when we talk about why, we understand that mortality rates for Black women with college education are higher than for non-Hispanic white women who don't have a college degree. So then we have to start delving into what is going on at the healthcare interface, what are the social determinants of health that are leading to these disparities. And I think that these overwhelming numbers, the numerous stories in the news about this situation are causing this call to action. The First Lady's initiatives are amazing in New Jersey, but there's a national pull to recognize, identify, and strike down the racist policies in healthcare.
Thank you. Kind of talking about where we are right now, kind of want to talk about what are the causes? I know you kind of touched upon it, but what are the different factors that are leading to the maternal health disparities that you're seeing?
So again, much of it is historic. So when you talk about the rates, the different rates of mortality in women, you have to back it up to think about what's causing the mortality. So women are dying from hemorrhage, which is just losing blood at the time of the delivery or thereafter. They're dying from cardiovascular disease, and that could be high blood pressure or heart muscle disease, heart disease. They're dying from infection. They're dying also from embolism, pulmonary embolism. Those are really the leading causes of death. So when you think about what makes those disparities for those diseases different in women of color, you have to think about what is the access to care and how are those conditions treated. 53% of maternal mortality occurs in the postpartum period. So that's after the woman has delivered. Some of it happens in the hospital when she's still there, but a large amount happens when she's already gone home. So she goes home, but she has a problem. So how does she get back into care? Does she have appropriate education to know about the signs, warning signs of post-birth warning signs? Does she have access to care to get back to the hospital? Does she go to the same hospital where she delivered? So many social determinants of health impair the woman's ability to access care. And then there's also the healthcare interface. When she complains of a problem, is she actually heard? We all heard the story of Serena Williams, a tennis star, who after her delivery, she had pain and she understood very well that she was having a pulmonary embolism or a clot in her lungs, one of those leading causes of maternal death. And when she asked for help, even Serena Williams was not listened to. We know other stories of very high profile women who have made the news, and then those who did not make the news, where they were not heard. So one cause is being heard. And the Center for Disease Control and Prevention actually has a campaign promoting against that. And it's called the Hear Her campaign. It empowers women to listen, to be listened to. It empowers healthcare providers to listen to women. It empowers families to encourage the patient to speak up. And literally it's scripted. It's a card. Center for Disease Control and Prevention has a card. It says, when you go to the hospital, you say this, you ask this, so that you can let your voice be heard. So, the care at the interface, access to care, how women are treated, how they're educated, all contribute to these disparities.
Thank you. I think, as you mentioned, it's really multi-pronged of different causes and factors that seem to work together to cause the disparity. Like you said, they're not being heard, not having access to the care, just multitude. Like you said, social determinants of health that's causing Black women, or harder for Black expectant parents to be heard or get access to it. And like you alluded to, there's also a lot of historical roots that kind of led us to where we are now. Historical history of having access to reproductive care. I just want to point it to Erin. How has historical access of reproductive care to women or Black women impacted what we're seeing today, and what has it been in the past, and how is that influencing it, what is happening today?
Right. Well, I think we all know, hello, everyone. I think we know that there are books, dissertations, movies on that question. And so I will try to very briefly summarize it for the context of just this conversation, because we could spend forever and ever, unfortunately, talking about that. And so I will just say that cis women, trans men, and non-binary people of color have a long history of struggling to access medical care in this country. So for Black people, particularly Black women, the history goes back to chattel slavery. Enslaved women were accused of feigning illness more often than enslaved men, and their health complaints often had to do with reproductive complications. Stereotypical representations of enslaved women feigning illness to get out of work, or get out of working in slavery, still lives with us in our regular treatment still in 2023. And as many may know, the practice of obstetrics and gynecology was built literally on the bodies of Black women, as people like Marion J. Sims and others practiced medicine on Black enslaved women without consent, without compassion, or without concern for their humanity. And even today, people continue to experience and have examples to point to where people they know, or people sharing their stories, explain how they have been mistreated, sterilized, still today, neglected and disrespected by the people who take oaths to care for them. And so Black women experience stillbirths or pregnancy complications, or even seek drug dependency treatment while pregnant, and often find themselves involved in carceral systems and handcuffs and childless because they went to the doctor because they were seeking care. And now, in the wake of various US Supreme Court decisions that are overturning our rights to bodily autonomy and voting and other fundamental protections, it is an unfortunate reality that the reproductive care that Black women and Black people, and particularly Black parenting and pregnant people have, will continue to be impacted. So there is a clear history of reproductive justice and collective struggle that we must reckon with the roots of both of these histories in the Black communities and beyond, that require accountability from the systems who have created and perpetuated the harm to Black pregnant people. And I know that we all here at DCR and others as a part of this panel are really working against those erosions of our laws, and importantly, coming together to really discuss and workshop how we can ensure that at minimum, at least in the state of New Jersey, we are working to build trust within the communities who've been so traumatized in medical and healthcare settings. Pardon my voice, it's allergy season. Thank you.
No worries, thank you. And thank you for bringing that historical context and really linking how what we've seen in the past with chattel slavery and the lack of access and control of reproductive access for Black expectant parents and mothers is still happening today in different ways, but they're really linked. It's not something that's just disappeared in the past, but it's happening today in different ways and appearing in different systems that we need to be aware of and just keep our eye on and pay attention to and move to change as well.
And if I could actually add to that, the medical system is very much understanding its own inherent racism. And so there's something in the medical community called algorithms that can predict the likelihood of a person doing well with a condition or treatment or doing poorly. So for example, for Black women, it was long decided that they had a different threshold for being anemic. So you didn't have to treat them for anemia because they were thought to have a lower blood count than non-Hispanic white women. And so that led to more women maybe hemorrhaging or needing a blood transfusion. There's an algorithm for having a vaginal birth after a C-section, which is a good thing. It can decrease the risk of complications, and it's much safer to have a vaginal birth than it is to have a cesarean delivery. But women may have been denied the opportunity to have a vaginal birth because the algorithm said, well, if you're Black, your success rate is going to be lower. But medicine has now been called out on some of these algorithms, and the medical literature is being rewritten and reclassified. And so those algorithms promote racism. And this is in 2023.
Well, thank you for bringing that up. Because I think that's something we, as people who might just be patients, when we enter the hospital or medical field, we are affected by it, but we might not know the algorithms, like you said, how that past algorithms are being done by doctors, seeing kind of that insight in it. And it's good to see, as you shared, that it's being recognized, it's being called out and changed. Thank you for adding that. I think that's important to definitely look at and consider. I want to see if Crystal has any insight you want to share about the different kind of causes or add to the causes of the disparities that you see.
Absolutely. Thank you for asking me as well. As a doula, we're there as, support people for our birthing mothers and our birthing people. And we teach them how to advocate for themselves. That's something that's so critical in this space, right? Because it's not always about not knowing, not asking questions, but not knowing the right question to ask. And so, The lack of education, especially in childbirth areas, has proven to be very dangerous for Black birthing people. And so, you know, that's really drives this, right? Plus, there's also the regular occurrences, because there's a kind of a known or the expectation that the patient is not as informed. What you're also seeing in this space is a lot of uninformed consent being given, right? Where, you know, you don't really know what it is you're saying yes to. And more importantly, oftentimes our birthing people don't know what they can say no to. And so that is what also highly contributes to disparities and the numbers that happen. We end up in these spaces that maybe we didn't have to be at, based on the lack of information. And again, more important than an uninformed yes, it is really the uninformed no that you could have had. That could really save a lot of lives in this space.
Oh, thank you. That's, I think, is really key, because like you said, you don't, not sure what you're saying yes to, or not even sure what questions you should be asking or what you're even thinking of. So I think you kind of bring that up is so important and critical to this conversation. Kind of,
Can I hop in very briefly, Kai?
yeah.
Just to piggyback off of what Crystal was saying. I think it's totally true that we are just often uninformed. And sometimes because of that lack of information, we don't know what we can say no to. But I think it's also as important, probably Dr. Williams may know better than I, that there are oftentimes in the waivers when we're seeking care, healthcare, there's so many forms that we get. We used to get them on paper. Now we get them on a laptop or what is it called?
Tablet, something.
Thank you, iPad or something that you're clicking through, and you're just waiving your rights. And I will say that sometimes you will not have an ability to not waive those rights, to be able to seek care. And so I think it is important to say, sometimes you absolutely should be reading it and be informed and ask questions about it. But also there are many times, I imagine, particularly when you are pregnant and expecting or birthing, that you're not going to read through all of those things. And so just also know that there are times that you will not be able to say no, or will not feel equipped to do so. And that too sometimes is okay. I don't want people to feel like, well, I don't know these things, and so it's my fault that I may have experienced some levels of trauma. And that is not true. There's just a lot of legal reasons and policy reasons why you may not. And that too is sometimes very unfair. But it's also important to note that you won't always have the ability to say no to waiving your rights to seek care.
And I would also just say that if I were counseling someone, I would say, whenever you feel that bit of uncomfortableness, am I signing this? Do I not know? Just talk it back. All you have to do is say, let me make sure I understand. Did you say X? And try to repeat what you think that you heard. Because if you heard it wrong, then the provider is going to correct you. They will have the responsibility to correct you. And it's okay, because a lot of medical information is really complex. You know, risks and benefits and alternatives, and, you know, the likelihood that this can happen and that can happen. And do you want a transfusion? And you might need a hysterectomy. And there's just a lot of information going out there. And it can be very scary on that very day that you're coming in to give birth. But you really have to make sure you're talking back those things that you feel that you don't understand. So you're very clear about the therapeutics, particularly those therapeutics that are going to cause you interventions that can cause risk and harm.
Yeah, thank you. And kind of on that topic, how can we advocate for ourselves in the medical facilities or like throughout our pregnancy? Like, what are ways and resources that we can advocate or think about, or what should we even think about, be aware of beforehand?
Well, I can start with that. And I would say, like, thank goodness for doulas, because having a doula and having another person in the room, it's like the modern day having a cell phone whenever you're out in the street, because women need that extra pair of eyes and ears to help, to listen, to help them explain things to them, and to be, and also to witness the beauty of their birth. So I really think that all patients should be encouraged to have a support person at their birth. The NAACP is running an initiative which is the maternal experience survey, where they have been asking women throughout the state about their birth experience. And data from that has shown that 11% of women, and the survey goes to all women, but it was predominantly geared towards Black women, but 11% of women were delivering without a support person. Sometimes that's because, they come from a culture where they don't have family here, a partner has to work, mother lives in another state. There's many reasons, but once you know that you're pregnant, I think a really important thing is to just figure out who's going to be there with you. And if you can get a doula, get a doula.
And if I could just jump in, thank you so much for that, Dr. Williams, because, in addition to our physical support and emotional support, we are a wealth of information. And when we work with not just the birthing person, but their partner as well. So we're able to help them get a lot of information that they don't have to necessarily run to Google and be overwhelmed by all the information that's out there. You're having this informative conversation with someone who you're building a rapport with. And from the very beginning, you brought them into your space because they're in your corner, right? So it's a trusted person, it's a trusted messenger. And that's really critically important in birthing spaces. And so when it comes to resources like that, we also, help provide or linkage to resources beyond just the labor and delivery support, because a lot of times when we're looking at some of these disparities, we're also talking about social determinants of health. So, some of our families may be in an area where they're in a food desert, right? Or a transportation desert. We have those kind of resources usually right at our fingertips to be able to help that family thrive, right? Not just survive, but really thrive beyond the labor and delivery room. Doulas offer a wealth of information. Sometimes if a client hasn't been encouraged to go out and do childbirth education, we're able to provide that as well. All these things are resources that can come straight from your doula, before labor and delivery, and certainly thereafter as well.
Thank you. And Crystal, talking about doulas, kind of explain what it was, but can you elaborate more on what is the relationship between the doula and the patient, and the doula with whether it's a doctor or midwives, how does those relationships work, and how do you work with birthing parents throughout it?
Absolutely. So a doula, we're trained professionals, we're trained labor professionals. If you're a birth doula, there's a lot of doulas out there. So just to use the term doula now is probably not as responsible as I could be if I don't preface it by saying a birth doula or a postpartum doula, right? And many of us are trained in both. And so, our full attention and focus is on the birthing person. And in addition to supporting their partner, if they have one, we don't replace the partner because we are not clinical. We certainly don't replace the obstetrician or the midwife, but we do work very well. We are a very valuable part of the birthing team in providing care for the birthing person and their family. So, leading up to it, again, like I said, there's a lot of informational support, whether it's childbirth education, other resources and linkages. But in the labor and delivery space, we are really there beyond the comfort techniques that we do. You might see massage therapy and other mechanisms for comfort management. I never use the term pain management because birthing is beautiful. So, we provide different measures of comfort techniques. But also, sometimes it's that additional support to the partner that's really important in this space where, sometimes the partner may not know how to advocate or may want someone they could speak with on not on behalf of the mother or the birthing person, but in support of, right? And so we work hand in hand. We're the ones who are really maintaining that labor and delivery space outside the presence of the obstetrician or the midwife. We're that continual support through and through. So when the doctor comes in to check, we're there. When the doctor steps out to check on others, we're still there. And so, we always encourage you to, get your doula as early as you can in your pregnancy, because it gives you a longer opportunity to cultivate that very trusting and close relationship. There's very few events that are more intimate and more important or more celebrated than your birth. So whoever's in that space with you, you want them to feel pretty special to you as well. And that's what we try to do as we come in and support.
Thank you. And then I guess kind of another question that you talked about, maybe think about. So if someone's looking for a doula or in search of it, what are things they should consider or think about, like what they might want in a doula, or even personality? Like what are things people should consider when they're starting this journey or thinking about finding that support?
Yes. So I guess I would say from a more formal standpoint, you do want to look at the training and their expertise. Those things are very important. But you mentioned personality, right? Your instincts are very important, even in this space, when it comes to the selection of your doula. You want someone who's going to be a good fit for the birth story that you want to end up having, right? Your doula is going to be there and help you, create your birth plan. And they're in one of the most intimate spaces you'll ever have. And so when you go out seeking a doula, you should interview them just like you should be interviewing your obstetrician, and just like you should be interviewing the pediatrician that you're going to select for yourself. There's no different when it comes to your doula, because you want to make sure that everyone's going to be a good fit for you and the family you are creating. Whether it's your first birth or your fifth birth, you're a new mother each time. That space is still sacred. And so you really want to take all those things in consideration when you're looking to hire your doula. A lot of times cultural reflectiveness is also very key in this space. I think that we know, as we've already touched on, the historical harms and, with medical racism, and even as we're still, finding our way through that space of medical racism now, that cultural congruence is also really important. Not to say someone who's outside your culture cannot support you, but there is a kinship there that's very different, and I think is also very helpful in this space.
Thank you. And then kind of that question for Dr. Williams, when someone's thinking about pregnancy or like thinking about who should be their healthcare provider, doctor, what should people think about or consider?
So again, likewise, they should consider their professional credentials, looking for an obstetrician that's appropriately credentialed, or a midwife that is appropriately credentialed. But it's also important to think about the facility where you're going to birth. And so in obstetrics, there's something called levels of maternal care. And so the highest risk patients, it's recommended that they deliver at hospitals that have an abundance of resources. So for example, a mom that has cardiac disease, or had heart surgery, or has kidney failure, that mom needs to deliver with a high-risk obstetrician with an interdisciplinary team. A mom with fewer problems or with no problems might consider birthing in a birthing facility. So you really need to think about what are your underlying conditions and pick the birthing hospital that is appropriate for you. But then there's also things like location. You might think this is the greatest hospital in the world, but it's like 2 hours from your home, and that might not make sense. Or you might choose to get care close to where you work, but then when it comes time for birthing, that is a problem because you might be far away. So there are also logistical things to take into account. But at best, you really want to have that feeling of understanding. You should go in and interview your obstetrician or your birthing attendant, whether it's a midwife or an OBGYN, the same way you would interview that pediatrician or that doula. You want to find out, what do they believe? How do they feel about cesarean deliveries? What are their policies on vaginal birth after cesarean section? That's something that you wish to have. What opportunities do they have for managing your comfort during labor? What does the facility offer? So those are some things to really take into account. I mean, there are other nuanced things that I think are somewhat also important. What's the ability to reach their nurse? How do you get to the office? Is there an emergency number? Do people answer it? Many organizations have electronic medical records, which are incredible because patients have access to their own data. their own medical record, and then they can also see their appointments and they can message through patient portals. This is really critical because fragmented care is one of the leading causes of maternal death. It's thought to be, and that's because because we're in New Jersey, it's a small state and we're mobile, right? Sometimes we go to the shore, sometimes we go to Jersey City, sometimes we go to Atlantic City, sometimes we stay in Newark, we move around. And so when a mother's getting care at different facilities and there's not access to that medical information, that can impair care. So the patient having their own information and the medical system being flexible are also very important safety measures.
Thank you. I think those for you, Dr. Williams and Crystal has said things to consider when you're thinking about pregnancy or searching for your support system is so important. Think about the resources, are you able to access it? You have a good relationship, or you're being listened or heard. I think that all goes back to finding ways to advocate for yourself in those spaces and having your voice heard when you're entering the medical spaces. I know there's a lot of initiatives. I think we kind of talked before that is addressing Black maternal health in New Jersey, across the country, but also in New Jersey. There's a lot of talk and a lot of initiatives going on, which is great. But I want to see from the panelists if what are some initiatives that you would like to highlight that are being talked about when it comes to Black maternal health, or which ones you think are the highlight and are kind of going in the right direction, or that could be really good things to focus on and support?
Well, I'm particularly concerned about the number of women that die in the postpartum period. And remember that for all of those that are deceased, there's some others that suffer something called severe maternal morbidity. That means that they have really life-threatening things, but they made it. They went home. And the healthcare system might consider that a success because they walked out the door. But to that mother, that might be a traumatic event that affects her family and her life for the rest of her life. Maybe the baby delivered prematurely. Maybe there was a stillbirth. So some of these events can be really, really traumatic. So I'm really concerned about the postpartum period. So what's really exciting to me is that New Jersey is one of the first states that is expanding Medicaid coverage for pregnant women for 365 days. That means that they can continue to access care long after they leave the hospital. And so the predominance of deaths occur in the first 2 weeks postpartum, but maternal deaths can occur up to 1 year postpartum. And 42 days to 1 year is when most deaths that occur for cardiac disease, that is cardiomyopathy or heart muscle disease, or deaths from homicide and suicide. So in that postpartum period, it's really important that that mother is getting to, whether it's her obstetrician, getting handed off to a primary care doctor, has a postpartum doula that's looking in on her and making sure that she keeps up with her appointments and that she has that, those mothers with high risk problems have that transition of care. So that is one initiative that I think is going to be game changing for maternal health. And then, there are many other initiatives that have been put forward by the governor's office and also nationally.
Thank you. Crystal, are there any initiatives that you want to spotlight or highlight, or think it's game changing and moving in the right direction and addressing Black maternal health?
Yes, I'd actually like to piggyback on Dr. Gittens. I'm very happy to hear about the Medicaid postpartum care extension, because actually I from a different perspective, having that there is really it is a game changer. What I'd like to see it do also is start to put the pressure on private insurers to do the same. Because with them not getting on board doing that, you're still leaving out a very vulnerable population, particularly with Black maternal health. As Dr. Gittens already said, a more educated, higher socioeconomic status Black woman's going to fare worse in birthing situations than a white woman with a high school degree, right? And so, our Serena Williams, right? Again, certainly I'm definitely not in her socioeconomic status, but she was very vulnerable and her life was certainly at risk, right? And I'm sure she carries private insurance, but her private insurance, I'm sure, doesn't have, postpartum care for that year after. So I'd like to see that become more of a trend. So it gives me hope that maybe as the private insurers, are in tune to the fact that their members are also experiencing the severe maternal morbidity, but also their members who names show up in maternal mortality reports. Maybe they want to get on board and start to change this trajectory as well. New Jersey has a long way to go. New Jersey is the fourth most dangerous state in the country to give birth. So I don't think that we can afford to only have one side of insurance leaning in that direction when we have to protect all of our mothers and all of our Black mothers. So that definitely gives me hope that from a perspective that maybe there's some pressure out there to look at it in the private insurer sector. What also gives me hope is that there are a lot more community-based doulas out in New Jersey that have been trained and are on this ground. They've been on the ground called as healers to go into these birthing spaces. And so I think we have to continue to uplift and support their very presence, our presence and what it is that we're doing, and the why we're doing what we're doing. And so the fact that there are so many across the state of New Jersey, especially in New Jersey's maternal toxic zones, birthing deserts and the like, that gives me some hope that, we're starting to take this accountability back into our own hands. Birthing and midwifery, we all know that those began in the hands of Black women in the first place, and they were systemically pushed out. But I think when you see this rise of Black doulas and us really being in the birthing space, it gives me promise that we are coming back into this space as the healing hands that we've always had to really support and help provide more safety for Black birthing people. So that's what gives me hope, and I would love to see a continued support for Black doulas in the birthing space. And I do say that very specifically, and I'll just say this before I wrap. Just to kind of piggyback on my previous question and to even answer this, it wasn't until you start seeing more Black doulas in birthing spaces in New Jersey, then you start seeing the questioning of our credentials and why we're there and what we're doing, right? And so when I say lift up and support Black doulas, that's why I say lift up and support Black doulas, because we come into this space, number one, it's always a calling. And number two, we're supporting those who are most vulnerable, right? And so, to answer the earlier question, when you're looking at the interview process for your birthing team, you really want to make sure that you do have an obstetrician or midwife who's on board with you having your doula in that space as a respected part of the birthing team.
My turn. That's what I thought. That's great. I really like the way, Crystal, you framed it and what gives you hope. I think that's really beautiful, because so often when we're talking about this and so many issues, but this issue in particular, it can feel, I'm sure to many, very daunting and hopeless, especially when we talk about the history. So I really appreciate that. And I will start by saying a number of things. I think it's really important when we think about addressing maternal health by remembering, which I know we all do, but I think it's worth saying, that pregnant people are people before they're pregnant. And so when we're talking about maternal health, we often, I think about that period of time, sometimes 10 months, sometimes 6 months, sometimes a few months or weeks, where someone is pregnant, and whether or not they choose to carry to term or choose not to carry to term and become a parent or not. And we think about just a select period of time in a person's life. But there's so much, as we all know, like Dr. Williams, Dr. Lisa referred to social determinants of health, there's so much that impacts a person's health even before they're pregnant and then after they're pregnant. And so I don't want us to lose that there are so many initiatives that may not ever have the word maternal, or may never have the word pregnant or parenting or child or infant in it, that absolutely address or impact maternal health as a whole. So I just want to say that very clearly without going into all the initiatives that possibly is. But so with that in mind, I'll highlight a few things. few being more than two. So there are, at least at DCR, we have explicitly included a way for people to be able to select healthcare settings as part of our place, as part of our place of public accommodations in our New Jersey bias reporting system. For those who are familiar, very briefly, if you feel as if or believe or know that you've been discriminated against, harassed, retaliated against in employment and housing or places open to the public, which includes healthcare settings, you can come to DCR and you can book online, and you can go onto DCR and go to our NJ bias system and report that. Now, that is relatively new, only the past few years. In the past, you would have to come into DCR's office and report a complaint. But if you do that, where we used to just have place of public accommodation, we made sure when we rolled this out a few years ago during the pandemic that we also explicitly put a toggle where you can check off that you feel as if you've been discriminated against in a healthcare setting, because oftentimes people don't know what it means or what it feels like or what it looks like to be discriminated against in a healthcare setting, because you're in a room by yourself often, not always, but sometimes you're in a room by yourself and you don't have a comparator. Like, was I treated this way? Was I spoken to this way because I am a Black woman? Was I treated this way? Was I spoken to this way because they perceive me a particular way? And so we wanted to make it very clear as an option, because sometimes people need very clear options to know that they can choose something. So that's one thing DCR has done recently. We've also added a health equity and justice arm to our affirmative enforcement work. So the unit that I currently lead, we don't just respond to the complaints that I just described come into DCR. We will identify based upon what's in the news, based upon a systemic issue, based upon matters that come to us from larger organizations, and will affirmatively work to address an issue like maternal health, like maternal morbidity. And so we added specifically a health equity and justice arm to our policy efforts, to our enforcement efforts, leading us to collaborate with various organizations who are on the ground doing the work. We've also updated regulations that now explicitly require places open to the public, which already was required, but places open to the public to post Know Your Rights posters in healthcare settings. I'm sure those will be dropped because they're on our website. I'm sure those will be dropped in the chat, but we have some specifically featuring Black pregnant people and asking them, have you experienced this? Have you experienced a feeling that you are being over tested or being over questioned? And those posters or versions of those posters are required to be displayed and to advise people of their rights against discrimination and advise people who are working in those places of their obligations to affirmatively ensure that they are not discriminated against people. So those are some of the things. Obviously, DCR is also here. Those are some of the things that DCR is doing. I will also highlight that there is some legislation that is pending. At least the last time I checked, there's A804, which requires midwives and physicians to provide pregnant people. I mean, it says the law says women, but I refer to pregnant people, information on birthing options prior to delivery. So that's a pending bill before the New Jersey legislature. It has not moved since last year. So if people wish to support a bill like that, they can reach out to the legislators and indicate that they are in support. And then there's also A822, which is the New Jersey Domestic Workers Bill of Rights Act, which amends the law against discrimination, which is one of the laws that DCR enforces, to include domestic workers who are currently not included in the definition of employees. And while this may not immediately connect to maternal health as neatly as we sometimes expect, it's important to know that most domestic workers in New Jersey are women and women of color. And this law will allow for those who experience discrimination, harassment, or retaliation in employment based upon their protected class, like race, their gender, and their pregnancy, to have recourse under the law and file with DCR if they feel like they're experiencing that. And so any bill that protects people with the capacity for pregnancy or capacity for pregnancy's well-being and civil rights, to me, is also connected to maternal and infant health. And I will add, as part of that, our Fair Chance in Housing Act, which is a new law, first of its kind, one and only law in the nation that protects people to ensure that they have housing, even when they have a criminal record, because it is an unfortunate reality that many people, many housing providers discriminate based upon a person's criminal record and tell them they cannot have housing. So there are a lot of criteria that housing providers are required to consider before they can even do that. And I highlight that again because Black women in particular, are more likely to be evicted from their homes and to find it more difficult to find housing consistently. And that is only even more difficult when you have a criminal record. So again, to my larger point about all of these civil rights laws, to me, impact maternal health and well-being around the state.
I'm so glad that you discussed all of those things, because it's very clear for me, doing direct patient care, that there are so many women that have difficulty with employment in the postpartum period, not getting off of work to come to their appointments. We know that women make 80, 70 cents on the dollar in general to men, and the disparities are even greater for Black women. So the United States is the only country that doesn't have prolonged maternity leave. When you look at those other countries, those other industrialized countries that have better maternity statistics than us, they respect and they treat women in the postpartum period and during the pregnancy very, very different than here in the United States. So those initiatives, I really agree, and I really applaud your work in those areas, because everything that affects human rights and that affects workplace and gender discrimination and pay equity will all affect pregnant women, and that I see every day.
Thank you. As we heard from the panelists, there's a lot of initiatives, a lot of action and focus on policy that's happening across the state to really address Black maternal health, the disparities we see in the health outcomes, really to support birthing parents and birthing parents of color, Black birthing parents. There's a lot going on there to support and moving us in the right direction. There's still a lot that still needs to be done, but there's a lot that we can support right now to get behind and elevate and continue to advocate and ask for more and demand more. Before we go to question and answer, I want to allow the time for all the panelists, if there's anything they want to contribute or add to the discussion that we haven't touched upon yet. And then also, in addition to that, what's one key thing you hope the attendees will walk away with, remember from this, or share with their community?
I can start with what I would like people to know about that we haven't touched on, because DCR often focuses largely on the law against discrimination. I do want to highlight a few points about the Family Leave Act. Again, to refer back to my point about employment and what Dr. Williams just referred to. So it's important to know that people in New Jersey have access to the New Jersey Family Leave Act. So if you work for a state or local government agency or a company or organization with 30 or more employees worldwide, not just in the state, but anywhere in the nation, and you have been employed by the company for at least 1 year, you generally can take up to 12 weeks of job protected leave during any 24-month period to care for or bond with a child, as long as the leave begins within 1 year of the child's birth, or placement for adoption or foster care, to care for a family member or someone who is the equivalent of family with a serious health condition, including a diagnosis of COVID-19, to provide required care or treatment for a child during a state of emergency, if their school or place of care is closed, like during an epidemic. And you can take a consecutive block up to 12 weeks of leave, or you can take leave on an intermittent or reduced schedule. And it's really important to know that under the NJFLA, leave is not the same as the FMLA, which is often confusing, I know. So you will not use up all your NJFLA leave when you take leave for your own serious medical condition, because FMLA is about your own medical condition. FLA is, like I just described, taking leave to care for other people, including your child. So in some situations, you therefore may be entitled to take up to 12 weeks of FMLA for yourself, after you just had a baby. You can take up to 12 weeks for pregnancy and recovery from childbirth under the FMLA, and you can then take an additional 12 weeks of NJFLA leave to bond with or care for your baby after your doctor certifies you are fit to return to work or you've exhausted all your FMLA leave. So I think it's really, really important to highlight that when we're talking about the protections that people have to ensure that they are getting healthy. And also advocating for yourself, even with your employers, to understand what they are required to give you in the state of New Jersey.
Thank you. I think that's important to know because I think a lot of people don't know that NJFLA is different from the federal FMLA. Thanks for pointing that out, Erin. I guess we can move to Crystal. Anything that you want to contribute to the conversation or something that you hope that attendees will take away and share?
Thank you, Erin. Thank you so much for that breakdown, because that's where I was getting ready to go next. So many of those provisions are under the CARE grant and the CARE Act, right? And there's so much information out there. The Know Your Rights pamphlet that'll just give you the pocket-sized breakdown you can take with you anywhere, so you kind of walk into your places of employment feeling armed with knowledge and information on how to protect your rights and utilize these things that are afforded to you. So I won't spend time there because Erin broke it all the way down, but it's so important that people do know those things. I guess my biggest takeaway is that, or I'd want people to walk away with just knowing that New Jersey has a long way to go, and I don't want to, like I said, but I do still have a space of hope, but that hope will really come because it comes from a place of knowing that there's so many different entities working to attack this huge problem, right? There's no one way that we're going to just totally clear up these disparities and make safer birthing spaces for Black mothers and Black birthing people, right? So I'm very excited to know that Division on Civil Rights is coming into this space. We were talking about civil rights and human rights, and I mean, this country is the only country that had civil rights. Every place else always referred to it as human rights. So knowing that DCR is on board and moving into this space is very exciting, because one of the things that I see on the advocacy side and the activism side is that we don't find a lot of accountability measures, and people don't know where to turn, right? So we see a lot of initiatives that want to do to make things better, but oftentimes we don't see any consequences for the offending parties, right? And so I think seeing that DCR is in this space again gives me hope that maybe there's someplace else that we can now turn to. One thing I do want to lift up when it was mentioned that sometimes we go into these spaces and we're so conditioned that we don't even know sometimes that we've been discriminated against, and that's because all the weathering that we go through, that's what we live in, that's what we exist in. Recognize that when we're talking about unsafe birthing spaces, we're talking about everyone from the receptionist all the way through the entire continuum of care, right? And so we know that people are facing discriminatory and racial microaggressions right there, right at the reception desk, right? And so if you feel like that something has happened to you, utilize the different resources that have been given today, say something, because we have to attack it on all levels. And so if you know someone who is pregnant, considering getting pregnant, I encourage you to arm them with knowledge and information, encourage them to get a doula, encourage them to get a birth team that they're going to feel is respecting their bodies and their decisions. And we'll continue to make improvements here in New Jersey. Thank you for having me.
So, I would lastly add that I have been practicing obstetrics for over 20 years. And so if anyone read Linda Villarosa's book about healthcare, she describes a birthing situation where her companion, her friend, or family member is roughly treated in the birth space. And she's appalled by this, and it's in her book. And she studied healthcare her entire career. And I witnessed that. But I can say that right now we're seeing lots of change in the healthcare space. And so that respectful care is now being taught. We teach it to our residents and our trainees. Respectful care, asking the patient Is it okay if I examine you, right? We don't have a right to just examine someone. So if someone's examining you, you make sure they've asked you if they can touch you, can they examine you? It shouldn't be that the sheet gets pulled off of you and you get a pelvic exam. Language interpreters are extremely important. Again, 20 years ago, I did not see this. I see every single patient that does not speak English is having a language interpreter. And that interpreter is there during the labor process, sometimes helping us teach the patient how to push. I think I now know how to say push in 5 different languages myself. But those are the types of things that people have a right to. You have a right to a language interpreter. You have a right to respectful care. And so those are the things that I think that are really important. And I do like the systems of accountability, but make it known that these are your rights and you have a right to be treated in a respectful way in the birthing space. The other thing I would say is all of these things can make you really scared. So I've had friends say, oh my gosh, I'm afraid to get pregnant. I'm 40, now I'm even more afraid to get pregnant when I look at the maternal mortality statistics for older women. And I would say, you know what, if you want to be a birthing person and have a child, regardless of what types of comorbidities you have, find a doctor who can take care of you and who can manage those conditions. But do share your pregnancy. Get as early prenatal care as you can. Do not let fear impair you, because there's many conditions that we can manage, and they're better managed when we see you early in the pregnancy period. So do get care and seek care as soon as you do know that you are pregnant.
Thank you. I want to say thank you to all 3 panelists for all your insight and having a rich conversation about Black maternal health and looking at where we are in New Jersey and ways that we can improve and like what's out there currently to address it. And we have several questions in the Q&A. So we'll start the question and answer session. Attendees, you still have time to post your questions in the Q&A, and we'll try to get through all of them. If we are not able to get through all of them, we will send a response in email. But kind of looking at the first one. So this is from Denise, asks, says, most hospital and health providers have a patient's bill of rights. How can we strengthen this existing policy work for Black and Brown people who are pregnant and of postpartum?
There is a document called the Black Birthing Bill of Rights. You can find it. I can share the link. I don't have it right now. But it specifically lists things that Black women would want to attend to. So the hospital, in fact, does have the Bill of Rights of your respectful care and what your rights are. And they're typically posted in the hospital at the point of entry. They're in the emergency rooms and in the triage areas. But as a Black birthing person, I recommend looking at the Black Birthing Bill of Rights, bringing it to your provider and asking her, he or she, or whether it's a midwife or a doctor, asking them whether they and their institution can adhere to that. And Crystal, you may have something else to add from the doula point on that.
Actually, that's the National Association to Advance Black Birth is who has the Black Birthing Bill of Rights. And that's something I actually give to all of my clients, encourage them to take that into that space. And so I don't have much more to add to it, essentially, because we were on the same page. But I think it's really important that, our clients kind of see the distinction, because your experience is going to be different going in there. And so having that, is a good resource for a client who wants to go a little further, or a patient who wants to go a little further, for not a patient for me as a doula, obviously, I say client. But Black Women Birthing Justice has a great book that will tell you about different ways you can go about advancing this work, right? So when you're talking about bill of rights, and it gives you a whole breakout of how you can affect the change depending on what space you represent. So it can be the recommendations for medical school. There's recommendations for community and faith-based organizations. There's recommendations for obstetrics and gynecology. There's recommendations for how policy makers can get involved in this space. So, and in that book, we'll give you so many accounts of what has happened to Black women and Black birthing people in these different spaces. And unfortunately, for those of us who work in this space, we've heard these stories time and time again. But seeing it there in one collective space, with the wrap up telling you how you can get involved, and really they're very concrete measures that if everybody's on board with, you can probably start seeing change, and including things like community accountability boards, right? That includes people who given birth at a facility and what happened to them, and you have everybody on board, including your from your policymakers to your hospital administrators to your obstetricians, and the very important nursing staff, right? So there's just so many things out there to help advance these kind of spaces.
Thank you. Another question. So going back to, sorry, my screen. So going back to kind of how to advocate, right? I guess a statement, but back to how to advocate for yourself in a hospital setting. Someone says sometimes people don't know the right questions. Black and brown people should be asking when they're advocating for their health. I guess what are some good questions that people should be asking when they're in the healthcare setting, when they're pregnant? What should they be asking in their healthcare providers?
Yeah, that's a pretty broad question, but I think you can capture it by asking, do I have any new problems or diagnoses that you haven't explained to me? Because sometimes a doctor will see the blood pressure's high, and now I'm worried about that. But if I haven't communicated that to the patient, then she doesn't know and her family doesn't know. And I don't want to be telling her 3 days later on the way home, oh, you had high blood pressure. Now you have to monitor it at home and now you have a problem. So I think that just asking it, have you explained all of my problems and my diagnoses to me? And that's our responsibility. So of course you can't anticipate a problem. You might ask, well, I saw you asking about this, or I noticed that you look puzzled when you listen to my heart. Is there anything wrong? Is my baby okay? Those are the general questions that are always asked. But you can broaden that by saying, have you explained all of my diagnoses and problems to me? Have you explained my plan of care? What's the next step? So that at each encounter, you know what to anticipate. I think that's really the best way to assure that your doctor has informed you of everything that you're going to be up against. And then with your doula, you also, if you're pregnant, you want to be making a birth plan. So you want to start asking. You don't have to know, you have your due date and your baby shower and it's all planned, but sometimes the best plans go awry. So you should be asking at each encounter, are there any risks? Am I on target for my plan? Might I be delivering early? Might my plan change? So you'll always want to be in that kind of dialogue, asking those questions about the plan. And you need to have your notebook, whether it's your notebook, your iPad, your tablet, wherever you have your notes, bring your notes to those healthcare encounters. You will be an informed consumer, and you'll be an informed birthing person.
I'll just lightly add to that, just from the doula perspective. When you're creating that birth plan, hopefully you're doing it as early as possible in your pregnancy, so you have the opportunity to go over that with your provider, right? Because you really want to know if they're on the same page with how you envision your birth to go. And if they're not, you might, again, ask the questions. Is it related to a medical condition that you haven't fully explained to me that you're not on birth? Or is it just a matter of philosophies not being in alignment, which means they may not be the best provider for you. And you can identify that earlier on than, them being introduced to your birth plan when you're having your baby. That's just not a good time for that. That's when you don't want to learn that that's the time that you and your provider simply are not on the same page. That's when things start to go awry. And in the event that, your birth plan has to be changed, you may not have the same level of trust that you should have in the event of having to make such, decisions in that type of moment. So I would always encourage you to do that early on and make sure you're having that open conversation, because once you've taken the time to create that birth plan, you really are spelling out what it is that you want to see along this journey. And you want to make sure that your provider can be in alignment with that.
Thank
Great.
you. Another question. One of the attendees posted that they work for a maternal child health organization and support pregnant and postpartum people, particularly in the southern region, with the highest Black infant and maternal mortality through a variety of community-based programs. Through a variety of community-based programs like home visiting. How can I make my programs more effective in combating Black maternal and child health?
Yeah, it is true that the southern part of the state has the southern and then the northern part have the highest rates of both maternal and infant mortality. So I definitely think the home visiting nurse program it's another one of these state initiatives that will be important, because not only will that visiting nurse check on the baby, but they'll also check on the mother. And that visit, whether it's in the first week or the first 2 weeks or first few days postpartum, again, can reduce maternal morbidity and mortality. I would say that very important information is coming out of that maternal experience survey, the NAACP initiative, where birthing institutions are allowed to collect data. They will be able to receive data on the experience of the woman in that healthcare space. And fairly soon, that information is going to be publicly available on the Prematurity Prevention Initiative's website. And this is the voices of patients. So we know that as doulas, you hear the story, but these are stories that will be collected and publicly available. They won't be necessarily attributed to a particular birthing institution, but they'll be aggregate data for around the state. And you'll be able to hear what people are saying. Ask them, then people will tell you what they need. So when in the most recent data that we reviewed, there are persons saying, I had everything, but I just didn't have transportation. I was an immigrant and I couldn't figure out how to get healthcare. I didn't have anybody in the delivery room with me. And sometimes there were reports of people being treated unfairly. In this resource that patients fill out, this survey, they can be connected. And I think that, your office is a great resource for them to be connected to as well, so that they can understand what their civil rights are. But those are resources that can be used to help that population in Southern New Jersey. Some of the deaths also in Southern New Jersey are related to substance use disorder. So Narcan programs are also going to be very important, making sure that mothers, if they're discharged from the hospital with narcotic, they have ability to treat accidental or even intentional narcotic overdose.
I have a little bit to add, and that was a perfect segue, actually. My suggestion is almost always to be as inclusive as possible, to include, because the work I used to do prior to coming to DCR was helping attorneys or supporting people who were criminalized related to their pregnancies, and that can include drug use during pregnancy. Again, centering that people are people, irrespective of their pregnancy. They will always be people, even if they're not pregnant. So making sure that you are inclusive of people's life experiences, whether they are using drugs, which is different than being dependent upon drugs. You can be using drugs and not be dependent upon it. So being inclusive, that if someone is making certain life decisions, that if you really are trying to serve their best and support their best care, is to be inclusive of whatever stage they are in, and open-minded to that. And so that also includes gender identity, asking people their pronouns, asking people about how they can want to be treated and touched or not treated, and to be included. I think it's always what I defer to when thinking about how to improve situations that allow people to feel welcomed, especially when you're thinking about people who are often, not always, experiencing levels of trauma throughout their life in various healthcare settings prior to even becoming pregnant.
And I just want to chime in. One thing we have to be cognizant of, sometimes we have wonderful, wonderful programs, but we're not doing enough introspection when it comes to what we're offering within that program, right? So the program itself, the idea of the program may be very good, but are we meeting certain marks, right? So, I know we always hear a lot about diversity, equity, inclusion. Is there representation of the the community in which you're serving, is there a balance in the representation of the service providers, right? The people who are offering these services, because you may not get the level of participation you want if that's not there. Additionally, I always challenge people to go a step further from the diversity, equity, and inclusion to making sure that we're really being cognizant and really purposeful about practicing anti-racist treatment, right? Like there is a different, and there's we want to make sure that's actually happening in the space. So, even if your cultural congruence is not really where it should be yet, those who are rendering the services need to make sure that they are also, rendering service from an anti-racist framework and model of practice, right? Because you can't go into a community, especially from which that you don't identify, and not check your biases at the door, because it will affect how you're rendering services, and it will affect how people receive your services, or whether or not they're even willing to come back or refer to your service. So it'll take a good idea or a well-meaning program, and it will not thrive unless you're not willing to kind of check what's going on within your own program.
Thank you. The next question, do doulas follow HIPAA regulations?
Yes, your doula should be following HIPAA regulations. It's part of our certifications and our training to learn what that is supposed to be and how you go about making sure you're practicing that. That's a question I would encourage you to ask your doula at the time of interview to make sure that they are keenly aware of it, and that while the relationship may not be as formal as maybe it is with your clinical provider, just because of the nature of our work, that does not preclude us from protecting your information. It's still a health space, and your information should be handled with the same level of privacy and security that you would in any other space.
Another question someone asks is, how has the COVID-19 pandemic affected the disparities? You're on mute.
The maternal mortality rate increased during the pandemic. So, I mean, that's very clear. And some of those maternal deaths were related to COVID-19 itself. One of the problems when we talk about, overall legislation for women is that women were not historically involved in pharmaceutical trials. So when the vaccines came out, pregnant women were not included in the trial. So there wasn't data for women to understand and feel safe early on about getting the COVID-19 vaccine. So many pregnant women didn't want to take the vaccine because they were concerned about their babies. At some point, we had data and we encouraged women to get the vaccine, but there were still those that remained unvaccinated. And those would be the majority of the COVID-19 deaths. So the pandemic did increase the rate of mortality. Again, many for other social determinants of health reasons, but also many COVID directly related deaths.
If I can just add a little bit, for what it's worth, Rutgers released a report, I believe last year, that showed that 90%, maybe even higher, almost 100 actually percent of the jobs that were lost during the pandemic in the state were women occupied. So I know that's not directly, my theme. It's not directly naming maternal health, but when people are not able to work, and thus are not able to care for themselves or their families, or maybe have health insurance, that too is going to lead to worse disparities in health.
And I just would like to add to it that COVID-19 exacerbated also because of the fact that when the hospitals had become more secure for obvious reasons due to COVID, there was also a reduction in support people that you can bring into birthing spaces. And so you had to kind of choose very early on in the pandemic. Birthing people were told they had to choose between their partner and or their doula, right? And so that's a very difficult decision. Fortunately, the Murphy administration did, issue guidance around that, indicating that doulas are to be allowed in the birthing space, but that did happen early on. But the other challenges that opened up from that, again, you were starting to see more doulas of color, Black doulas. And so they were, met with other obstacles, even getting in during that time, which was frustrating. Not so much for the doula. I mean, obviously for the doula as well, but imagine the birthing person. You've cultivated this trusting relationship with someone who's there to support you, who you're counting on, and then they're dealing with additional obstacles that may prevent them from even getting into the birthing space with you. And so, that also can, contribute to how disparities were exacerbated. So again, like I said, the Murphy administration did put provisions in there after a certain point. I believe it was like June of 22. It wasn't very late into the pandemic, but lives were already lost and people were already kept out of the birthing space. And then you really, as a doula, we found ourselves really having to prove who we were and what we were coming to do to really get into the space to be able to support our birthing people. And so that challenge was, something that was, directly caused by COVID-19 and the restrictions associated with it.
Yeah, and I'll echo that we were very happy that the Murphy administration put in the executive order to let doulas and also partners or family members in the birthing space. That was also very helpful to us. But we also had the whole element of fear of the pandemic. Many organizations converted to telehealth and they were able to still see their clients, their patients. But some organizations like a single practice physician's office that didn't have the capacity to convert to telehealth, some of those doctors had to shut down. Some of those facilities or those doctors lost their own livelihood because they weren't unable to stay open. And so it disproportionately affected minority communities and private doctors that might have been minority providers in these places, creating more maternity deserts. So there was a real flip to actually get care. And again, I speak to HR, I think it's 1117, which is trying to get pregnant women in clinical drug trials. It's actually passed through the House and the Senate. It's a bill. And again, when pharmaceutical companies trial drugs, they need to include pregnant women so that women can get early information so they can decide about varying therapeutics. That was something that disproportionately affected women in the pandemic.
Thank you. And we have time for a couple more questions. Another one from Martin. There are people from different cultures who are residents and citizens who don't have access to these stated rights or Bill of Rights and the laws. How can they be educated of these laws? How can they obtain the information?
If I can just say at the outset, if I understand the question, Martin and anyone should know that both the Patient Bill of Rights and all rights, particularly the ones I know, which are the ones that DCR enforces, are not relegated to people being to their citizenship status, if that's what I understand him referring to when he's referring to residents and citizens, certain citizens. So if you're a patient in a hospital, you're a patient regardless of whether or not of your documentation status. Most laws in New Jersey provide protections for people within New Jersey who come, who work, who live here, and you do not have to be a fully documented person. So I'll leave it to anyone else about the other parts of that question, but I wanted them to understand that part of the law.
I will say that I have a large non-English speaking population. Many are immigrants and from literally 32 countries in my prenatal clinic and speaking multiple languages. And I just think that the organization, I know that at the hospital where I practice, University Hospital, there's a strong commitment to providing equitable care across these varying populations and being culturally sensitive. So the organization has a responsibility to explain to you your rights, if there's rights, explain to you your consent, explain to you your paperwork, explain to you your instructions when you're leaving the hospital. We have instructions in multiple languages. We have language interpreters that are available really 24/7. And it's very rare, unless it's a really language that is not frequently spoken or very remote, that we have to take a little bit extra time to get a language interpreter. So those rights, to your point, Erin, these are rights that are afforded to everyone who is living in New Jersey in the healthcare setting.
The last thing I would also say is the last thing that I would say also is that, tap into your community resources. There are a lot of different organizations that are out here, grassroots organizations that have gotten into health equity spaces and are providing the same type of information that we're giving tonight. And so you might feel a little more comfortable with receiving it. Look to your credible messengers within your community. There's so many different organizations. You have Salvation and Social Justice as one space. We do that, and we do it through Black faith organizing, right? Recognizing the power in the Black church. You have organizations like the Latino Action Network Foundation. They're doing health equity work. The list goes on and on. So I would also not limit your resources to the medical centers or doctor's offices directly, but know that there are grassroots organizing groups that are out there getting the same information out to offer in maybe a place that might feel a little more comfortable, a little more protected. And nonetheless, you're then armed with the proper information and how to go about, assessing these or accessing these rights. As Erin and Dr. Gibbons said, you are afforded regardless of your status there. So thank you.
The partnerships for maternal and child health, there's one in Northern New Jersey, Central and Southern New Jersey. They're really a resource hub for patients. So that's a really good resource that can also connect you to many community organizations and also faith-based organizations. You can go to their website. Someone can put it there, the Partnership for Maternal Child Health. They'll direct you to the other partnerships throughout the state. And those can be incredible resources. And they are typically very well connected to all of the community organizations in this space. And also these can provide support for you as well.
I want to thank the panelists. I have maybe one more question, but also want to note to all the attendees, all the resources that the panelists are talking about, we're going to send them out following this webinar in a resource packet. So all the resources dropped in the chat and the ones that the panelists are talking about, we're going to collect them and send them to all the attendees so that you'll have it in one spot. I guess last question, have birth-in centers and center-in pregnancy programs proven to be more supported to Black/brown birthing people?
Well, centering pregnancy programs, am I still, I am unmuted. Centering pregnancy programs have been shown to improve birth outcomes. And it is the concept of a group and a circle. And typically it's like-minded women in your community who are sharing the same pregnancy experience. Pregnancies typically start at the same gestational age and then carry through. I've seen women through a centering pregnancy program become the best of friends, women that they had previously never met and had not met. And I've seen women who have been in isolation because they don't have families where they live and they don't have support systems where they live. They've created a support system and a network through centering pregnancy. So I think centering pregnancy is a great initiative, and if it's available and if you are inclined to be willing to share your experiences and be in that type of space. Some people, it's not for them and they're very private and they don't want to be in a group prenatal care setting. But in a group prenatal care setting, the education is communal, but the doctor encounter is always private. So you'll go to a private space and have your doctor visit and your exam, but then you'll share educational experiences and stories with your centering group. It can be tremendously helpful for women of color.
I want to say thank you. That is our time. I want to say thank you to Crystal Charlie, Dr. Lisa Giddens Williams, and Aaron Williams for taking your time out of your day and to join us in this very important conversation about Black maternal health. What is the disparities that we're seeing in New Jersey? What are the initiatives that are being done to address it? And how can we access resources or be aware of the resources that are out there to tackle the Black maternal health disparities that we are seeing? I want to thank all the team, Fanny, Patricia, Tabitha, Tisha, Jonathan, and Dave for supporting this initiatives on the back end with the chat and putting this program together. I want to thank all the attendees for joining us today. Thank you for coming here, learning more about Black maternal health. And I encourage everyone to take this information, share it with your community, share it with your network, and spread the word and to become more involved in this topic and discussion. I hope everyone has a great rest of the evening, enjoying the warmth. But thank you for joining us today for this really important topic and joining our panel and our discussion today.
Thank you.
Thank you. Good evening.
Thanks.
Thanks so much.